Sir, please come.
I thought there'd be a small group of 10, 15 people.
For the only andrologist in the city, we do expect a larger group.
So we should have titled the session, All You Wanted to Know About Viagra. It did not know whom to ask.
Sir, please sit. I was just going to crack a joke and allow me that. So the last time I attended Dr. Rupin Shah's lecture, it was a talk on premature ejaculation. I reached 5 minutes early, but it was already over. Okay, sir, thank you for coming. I have introduced you on a WhatsApp group already, and as an extension to the introduction, we usually conduct a rapid fire first before we start a talk. And that rapid fire can occasionally get a little personal. No, I'm just joking, sir. Just check your mic, please. Yeah. You've checked? Okay. I'm going to ask a few questions to Dr. Rupin Shah so that we know him a little better. If you weren't an andrologist, what would you be?
That's a long answer. What I wanted to be was a researcher in parapsychology, hunting ghosts and things like that.
Wow. Okay.
Then I wanted to be a psychiatrist, but when I did my residency in house post internship in psychiatry, I got so disillusioned that I dropped that.
And if it was a non-medical branch, what would you be?
Oh, then my fantasy is to be a park ranger in the American wildlife parks, which are stunningly beautiful.
Name one non-medical passion that you currently indulge in.
One
non-medical passion that you currently indulge in.
My passion is yoga.
Yoga, is it? Okay. We have several yoga people, including yoga teachers amongst the audience here.
Wonderful. So we'll switch topics and discuss the benefits of yoga and stuff.
I'll take your indulgence in a couple of more questions. Would you recommend andrology as a good branch for specialty?
So a lot of young urologists ask me that now, and that is interesting because when I took to andrology 35 years ago, I asked my seniors, should I take andrology? Half of them said, what? Sir, andrology. And many of you will remember Dr. Ajit Phadke, very, very senior urologist, who was like a mentor to every new urologist. I asked him, he said, Rupin, and he's a very gentle person. He says, Rupin, that's a very good thought, but there will not be enough patients, so I don't suggest it. But I still went ahead and did andrology. So what I tell people today is half of the same advice. I tell them that, see, I had the advantage of being the only one, so I pulled patients from everywhere. But if you're a young urologist, start by doing your bread and butter stone stricture and develop one area of interest, which could be andrology, urodynamics, female urology. And as you grow in your area of interest, move into that. So that's my advice.
How many andrologists are there in the country?
Urologists?
Andrologists who only do andrology?
Hardcore andrology, very, very, very few, maybe half a dozen or so. The rest are urologists who do andrology, and every once in a while I come across a letterhead, gastroenterological surgeon and andrology. So that is also the kind of andrologist we encounter.
Nice, thank you so much, sir. We will start the talk with first topic would be erectile dysfunction, if you're comfortable.
So
okay.
Since you started on premature, I'm sorry, was I late coming in? I thought it was 10 o'clock.
No, you weren't late.
Okay. So at least I can say I did make a premature entry.
And you won't have a premature ejaculation. He had to go out and, I think, fetch his parents from somewhere, but we have pulled him down. Okay, erectile dysfunction. First of all, if you can tell us about the etiology of erectile dysfunction, because the common belief is that psychological factors are more important than organic factors. Is that right, and how do we go about that?
I think that's a very important question, because if you read Western literature, you would read that the majority of erectile dysfunction is now considered organic. And this changed in the 60s, and since this is a lovely conversational morning, I'll ramble a little. Till the 60s, Masters and Johnson's ruled 95% of sexual dysfunction was thought to be psychogenic. But 60s was the time when sleep labs became very popular, and people were made to sleep, and everything was monitored, EOG, EEG, muscle, everything. And they realized during that phase that all men during REM sleep would get erections. And when they investigated further, they found that a man who had a physical problem, diabetes, hypertension, his night erections were very weak, whereas young men had strong erections. And this nocturnal erection monitoring became a tool to distinguish psychogenic versus organic. And with that came the realization that you were leading to, that in the Western population, the vast majority of sexual dysfunction was actually organic, not psychogenic. And that's what the textbooks now say. However, in our country, that is still not true. Because we don't have good sex education, we still have widespread sexual myths, misconcepts. Every week patients will come, "Saab Dhat jata hai, kamjor ho gaya, main to suicide kar dunga." So because of all these problems and the fact that still a large proportion of marriages are between people who are not sexually experienced, psychogenic sexual dysfunction in our country still very common. Of course, we are also the diabetes capital of the world, and 50 to 80% of all men with diabetes will eventually have a sexual problem. So we have both. We have a large number of organic cases who are often missed, and of course a huge number of psychogenic cases also who need help.
So after what age of cutoff age would you say organic exceeds psychogenic?
So generally after 50 it will be more organic. But actually we have three groups. We have the under 30s who are primarily psychogenic, but bear in mind that a small proportion may have an organic problem, so they are not all psychogenic. Some of them may have a congenital vascular dysfunction and therefore not get an erection. One patient we saw day before, married, but since birth his penis is curved like this, and therefore he is unable to consummate the marriage. Then we have the 60 plus group who are at risk of all endothelial dysfunctions, diabetes, hypertension, hyperlipidemia, and the majority there is organic, but even in that group there's a huge amount of psychogenic overlay, because by then the man has lost interest in his partner or in sex. There are other distractions. So there is the physical part which makes it difficult to get an erection, but there is a psychogenic overlay. And now we are seeing a lot of people in the 30s and 40s. I call them the MNC syndrome. Working very hard, husband and wife meet on the weekend when they're already stressed out, tired. The guy is already a little overweight, his lipids are borderline, hypertension, and then the pressure to perform on the weekend. So there is minimal organic element, but it's primarily psychogenic. So it's a spectrum. And the reason why we need to understand is that day before in the papers you may have read a young man somewhere in Lucknow had a Priapism because he had too much of sildenafil, and the newspaper article said that young men should not be given sildenafil.
Okay.
Not true. We will talk about this as we go into that, but both these groups, and particularly the MNC group who's having sex on the weekend, they need that tablet to preserve their marriage. So we'll come to that. It's a very interesting topic.
So how does a family physician investigate for organic causes or confirm psychogenic causes?
And the question before that is, how does the family physician elicit the history of ED?
That's very
because
important,
a large number of patients suffer. So one, of course, you will know that someone coming with weight complaints back and forth, sometimes privately ask him, not when the others are present. Particularly talks of pain in the testes, pain in the penis, etc. That is the younger patient. The older patient, diabetic, hypertensive, it's better to be proactive. Your their best friend. So at some point tell them, now you have this problem. It is possible that it may affect your erection, and if it does, there are many possible treatments. You're leaving the door open, and often on the second or third visit, they will come and say, Doc, you mentioned that, I'm fine, but, and then the history will come out. So leaving that door open.
So eliciting on inquiry might be an important thing for us. They may not be forthright in telling us about erectile dysfunction.
And then, of course, how do you distinguish further? So one, of course, presence of medical risk factors will weigh in favor of organicity. Young patient, very anxious, tense, weighs in favor of psychogenic. If he says, Doc, in the morning I get a good erection, but with my partner it doesn't happen, obviously that is psychogenic. If he says, I was okay, but the first time I tried sex with my girlfriend, I failed, and since then I've lost my erections, obviously psychogenic. So a lot of the history taking is just common sense, as you ask them about sexual dysfunction in one situation or all situations. Spontaneous erections in the morning or absent. Masturbatory function and the type of erection, and then the medical risk factors. And often I ask them, why do you think you've got this problem? And the explanation they give is often a strong pointer as to whether it's psychogenic or organic. He'll tell you, no doc, one night I was sleeping and suddenly next morning I woke up with a cramping, and since then I've lost erections. So that's usually sudden onset like that, psychogenic.
Okay.
Whereas somebody says, no doc, over the last 15 years, it's been diminishing. It started with my hypertension, then the doctor changed my medicine and it worsened. And it's a progressive organic problem.
So would you say the principal organic problem is atherosclerotic disease of the penile circulation?
The commonest cause. There can be many, any form of pelvic surgery. Nowadays, urologists are busy doing radical prostatectomies, right, left and center. That will cause it. Radical cystectomy, any pelvic surgery, spinal trauma, fracture pelvis. But yeah, the largest cause would be atherosclerotic. That is why the saying, small ED equals big ED. In other words, in a man of 40 to 60, small ED, that is erectile dysfunction, should warn you of the possibility of the big ED, which is endothelial dysfunction. And many studies have shown that erectile dysfunction predates a cardiovascular event by 1 to 3 years, because the penile vessels are 1/3 the size of the coronary vessel. So when there is generalized atherosclerosis, the first symptom may be manifest in the penis. So we call it the penile stress test for the heart.
Basically, if you understood this, coronary arteries with a wider diameter may get critically blocked later than the penile arteries, which have a smaller diameter. So they may be the first indicators. On the flip side, if a patient with established atherosclerotic cardiovascular disease comes to them, which is more common than somebody will come with erectile dysfunction, should they become more aware of erectile dysfunction? Because those patients will have.
Sure, certainly. So all your patients with diabetes, hypertension, hyperlipidemia, who are potentially having endothelial dysfunction and atherosclerosis, are much more likely to be having ED, mild, moderate or severe. And only 10-20% of these men actually come forth and ask for help, but the rest suffer. They suffer, their partner suffers, the marriage suffers. So it's a very interesting point, because I've had couples come in their 50s and 60s. The wife has dragged the husband, and when he's gone for an examination, she asked me, Doc, do you think he's having an affair? Because he's not interested in me. And when I asked the man, he says, no, I'm not doing it because I don't get an erection. And he has diabetes and hypertension, but his physician has not told him or her that, look, now he has this condition, his erections may develop a problem. So it remains unspoken, unacknowledged, and has a huge psychosocial impact.
Varietal impact is, how does a physician investigate at their level vascular causes of ED?
So when you're looking at vascular causes, you're assuming that it's a person over 40, or he has a known history of diabetes or hypertension. Because if it's a young patient, 20, 25, then you don't want to waste resources doing all these tests. So once they are over 40, 45, from your side, one would be, of course, looking at all the parameters, and if they're abnormal, correcting them. Because just bringing down the lipids, normalizing the sugar, correcting the vitamin D, etc., may help many men regain erections. Evaluation from a medical perspective and correcting that would help. And it also becomes a major opportunity for advising lifestyle change. With your lovely assistant and I, we came walking up 4 floors. So that's part of my penile health program. So lifestyle change, very often, when a medical event happens, that's when the patient gets a jolt. I, in fact, even use male infertility as an excuse to get them to lose weight and exercise, telling them that that will help your sperm count. With erectile dysfunction, even more so. So that is one role where you can play an important part in helping their erectile function, but even more important in improving their overall health.
So amongst lifestyle diseases which may cause erectile dysfunction, you have mentioned hypertension, diabetes, lipid abnormality, smoking.
Oh, very much. Smokers are 3 times at greater risk of eventually developing erectile dysfunction.
Obesity.
Certainly.
And alcohol.
Alcohol, again, as Shakespeare said it,
increases the
desire but taketh away the performance. So many couples find that a glass of wine may actually make them more relaxed and their sex life is better. But somebody who is on regular alcohol will experience deterioration.
They said the beauty is in the eyes of the beer holder. Okay, so so these risk factors, if reduced or corrected, may improve ED. That is what we say, correct?
So that's what you would look for and correct at your level. And you will then also supplement it with something we'll talk about later, which are the PDE5 inhibitors.
Okay, before that, investigations. Do we do any investigation like Doppler ultrasound or anything at all? No.
The most abused 2 tests in the evaluation of male sexual dysfunction is the penile color Doppler and the serum testosterone. So we need to talk about both. See, the penile color Doppler just tells you what is happening to the blood flow in the penis at the moment of the examination. But most of these men, when they go for the Doppler, are extremely stressed and tensed. And then if they're given an injection of piperine, that's quite painful. And whenever I ask them, did you get an erection during the study? Especially if they have an abnormal ripple, say, no doc, it was nowhere near the erection I get normally. So the color Doppler is just opining on the state of his penis at the time of the study. So in my experience, the vast majority of penile color Dopplers are unindicated, wrongly performed, wrongly interpreted and misleading. So if at all it has to be done, and that should be very occasionally, should be done under the supervision and specific requirement of a specialist, but do not waste your patient's time, because it's not only a waste of time and money, it's putting the patient at risk. I've seen at least a dozen cases of priapism, of prolonged erection, following a penile color Doppler, because if it's a young man, psychogenic, they inject piperine, he'll get a full erection, it'll remain erect, the sonologist doesn't know how to treat it, and I know at least out of these dozen, at least 3 or 4 who are permanently impotent because their priapism was not treated. And this has happened in public hospitals, in large private hospitals, and in private clinics. So
piperine is an injection which is intracavernosal. We will discuss that later when we discuss treatment.
Yeah, sometimes I may take things for granted.
Yeah.
Thank you. It's always a pleasure when you have a very well-informed chairman. He makes sure that the speaker stays on track.
Under-informed chairman who knows how much information we all have. Okay. Should we go on to treatment, pharmacologic treatment?
Okay, investigation-wise testosterone.
Okay.
Again, testosterone, everybody thinks of it as the easy fix. But remember, in young men, sexual function does not depend on testosterone. This is contrary to what you may have read or thought. And we see it in our infertility clinic, men with Klinefelter syndrome. Tiny testes, low testosterone, still having sex. When you give testosterone, the sex life may improve a little, but even with low testosterone, men are functional. So usually, low testosterone is not the cause of erectile dysfunction in young men. And too many young men are wrongly given testosterone as a treatment of their ED, and that just harms them. In older men after 50, 60, where low testosterone can be an issue, that may need correction, and if time permits, we may discuss that so-called mythical entity, andropause, and see what to do about that. But testosterone labs are often incorrect. I've seen half the reports from one lab low, second lab normal. So it's a lab error, it's wrongly done, wrongly interpreted, and then wrong treatment. So I would recommend against both these investigations.
We will come again when we discuss what is hypogonadism, late onset hypogonadism, which is a subject that he specializes in. Okay, now pharmacologic treatment and psychologic treatment of ED. What would you go first with?
So they're not mutually exclusive.
Okay.
While I was walking, one of my old friends told me, Rupin, you remember that patient who had psychological problems? He still has a problem. The truth is that organic ED is actually easier to treat than psychogenic ED. It's a case of you can take a horse to the water, but you can't force it to drink. So when people have psychological problems, there are problems at two levels. One is only performance anxiety, where if you get them to perform, the anxiety is relieved, therefore the desire increases and everything improves. That level of basic counseling is within the realm of everyone and can be combined with temporary medication to give him a boost of confidence. Then there is a very deeply disturbed psychological profile. You have to bear in mind that almost 2% of the population has a same-sex preference, but they still can't come out by and large because our society is conservative, and therefore a lot of times people are forced into marriage where they don't have the sexual inclination. So that kind of a problem. Or childhood sexual abuse, very common and by and large underreported. All kinds, both male homosexual abuse and of course female abuse. And these can create profound disturbances, or paraphilias, or profound fear of pain or sexual distress. These are conditions that need counseling by a sympathetic counselor or a psychiatrist, which are hard to find. But yeah, those are the ones that are beyond your ability and beyond my ability. They need very specialized care. But a large proportion of the people we'll see will be the young man who's very anxious, just got married, couldn't perform, mainly has performance anxiety, and giving him basic sex education, which all of us can do, correcting myths and misconceptions, educating the couple together, and then giving him reassurance and medication that is within our ambit. So psychological support as well as the tablet. Similarly for the older couple in their 50s and 60s, now they've kind of pushed sex under the bed instead of keeping it over the bed. And there a little bit of counseling emphasizing how it's fine to be sexual at 50, 60, 70. It'll be once in a while, and when it is once in a while, you can take the medication so that one episode is enjoyable. So basic counseling, permission giving often, and the medication together, both would go hand in hand.
About the Dhat syndrome, which is another psychological problem that we often face, what would you do to counsel them?
So Dhat syndrome is a broad term that refers to a variety of symptoms, psychological and psychosomatic, arising from perceived loss of semen or from actual semen discharge. Now, if you look at the second part first, perceived loss of semen, sometimes while defecating when they press, a little bit of prostatic fluid comes out. That is perceived loss of semen. Or in the urine, they sometimes see phosphate urea and they think semen is going. That is perceived. But it could be actual loss. Nocturnal emission in a 19-year-old is inevitable. And that nocturnal emission remaining in the urethra and coming out in his first urine is normal. So we need to understand what it is that is disturbing him. Sometimes they'll say, Doc, when I'm on the phone with my girlfriend, sticky liquid comes out, I'm losing my semen. So that is again perceived loss. And we need to know that so you can correct the misconcept. So for example, if they talk of the sticky urethral secretions, I tell them when you see food, you salivate. Whenever you think of sex, this liquid will come, and nature has created it because it is meant to be a lubricant. Then they begin to understand, okay, it is fine. When they complain of nocturnal emission, I tell them that's a very good sign. It means that your testes is functioning well, but because you do not have a natural release, it is coming out in your sleep. I can give you medicine to stop it, but that will harm you. Not all get convinced. Sometimes they're very, very disturbed and they need antidepressants, anti-anxiety medication. But this would be the basic counseling that can be done at our level. To reassure them, clarify the myths, give antidepressants if required. And some of these men will say, Doc, I've totally lost my erection. So in addition to clarifying their myths and misconcepts, I tell them, see, get rid of all these fears, but since your erection has gone away, I'll give you some medicine for some time which will help you recover, and then you don't worry. And these are the men we may put on daily tadalafil for 10, 20, 30 days, because that would help their natural erections, and then their confidence would come back. So there's a combination of explanation, reassurance, and medication.
Even masturbation is considered sometimes harmful by some people.
Masturbatory guilt, yeah, of course, I forgot that. Great guilt over masturbation, which you have to reassure.
Guilt, yeah. Can we go to PDE5 inhibitors
Sure.
now? So, as you know, phosphodiesterase 5 inhibitors are drugs that increase nitrous oxide and cause vasodilatation and increase blood flow. What is your take on the utility? Where can we use them? Where we should not use them?
So very important to discuss this. And the reason is that I get many patients in their 50s. I prescribe sildenafil and they come back after a month. So what was the result? No, my wife said don't take it. My family physician said sambhade na lejo. That sambhade na lejo is a warning that there's something very dangerous. Be careful. And one patient told me that 6 months after his heart attack, he went to his cardiologist and told him, sir, now I'm fine, I'm walking, I'm doing my 1 hour walk every day, but what about sex? I'm not getting an erection. And the cardiologist told him, Jivu che ke nahi? Do you want to live or not? How come you're bringing up this question? So that is a level of ignorance in lay people, but more than that, even amongst doctors. Doctors telling their patients, okay, take it, but take it with caution is very common. So let us start by talking of how Viagra was discovered. It was discovered in a Pfizer lab outside London when they were researching a medicine to treat hypertension and angina. And in the phase 1 trial, the volunteers were refusing to return the unused medication. Because in phase 1 you take it and you have very strict tallying. Why are you not returning? No, doc, my BP didn't change, but my sex life really improved. So remember that it was first used to treat cardiac conditions. It's not bad for the heart. It will actually improve coronary vasodilatation. It is a mild vasodilator. It will lower the BP a little. Of course, once this was realized, the Americans stole it, and the final research took place in Pfizer, USA. And in 1998, it was presented at our World Meeting of Sexual Medicine. And untypical of a Gujarati banya, I should have bought Pfizer shares, but I didn't. A few months later, it became public knowledge and the Pfizer shares went up, but I remained a poor andrologist.
We should have bought now with Paxlovid and the vaccine coming in, but we have also not bought.
So the purpose of telling you this story is to highlight that these drugs do not harm the heart. They do not harm the kidney. They do not harm the liver. Because that is the most common misconception. And the misconception arose because in the first 9 months after the introduction of Viagra in the USA, there were, I think, 91 or 97 deaths after people consumed Viagra. And the reason why that happened is suddenly there were 1 million prescriptions, and men who had been sexually inactive for years and years were suddenly hyperactive, and their heart couldn't take that burden. They had chest pain, and over and above the Viagra, they then popped a nitrate. Now the Viagra, as you said, amplifies the effect of the nitric oxide pathway, causing vasodilatation. When you take a nitrate, you flood the circulation with nitric oxide. So if you have sildenafil in your system, and then the patient takes nitrate, there is severe vasodilatation and profound hypotension. So the only contraindication to all these medicines, Viagra, sildenafil, tadalafil, now avanafil, is you should not combine it with a nitrate in any form. People can take it with antihypertensives, they can take it with antidiabetics, you can take it with anticoagulant, with antidepressants. In fact, you can combine it with all other medicines. If somebody is on an alpha blocker for his prostate, you have to make sure that he's not prone to postural hypotension, but if his BP is stable, he can take it, no problem. The only medicine you don't combine it with is with nitrates for the reason that I explained. But because of these deaths, patients who are cardiac patients were warned that if you want to take the tablet, don't take it with a nitrate. Valid for many people, and once he's off the nitrate and he's capable of the exertion of sexual activity. So, sexual activity with a known partner involves 3 to 5 METs, metabolic equivalents, which is the equivalent of a brisk walk of 1 kilometer in 15 minutes and climbing 1 flight of stairs. There's a famous movie with Jack Nicholson and Catherine Hepburn.
She came down with a heart attack. He
came down with a heart attack, and he was told by his doctor, when you can climb that flight of stairs, you can resume sexual activity. And he's now dating this young girl, and half the movie is Jack Nicholson longingly walking past those stairs, until of course at the end of the movie he climbs up, and then you know what happens. So for anybody to take any treatment, not only Viagra but anything, you should be cardiac fit. So if your patient is playing tennis 3 times a week, going for a long walk on Jew Beach, climbing stairs, he doesn't need a stress test also before you give him the sildenafil. He may need a stress test because if he has ED, maybe he has a cardiac problem. So from that perspective, you want to check him. But if he's able to be normally active physically, it is safe for him to take a PD5 inhibitor. So the funniest thing I often see is prescription to a 25-year-old, sildenafil 25 mg after ECG. Makes 25 doesn't need an ECG. Nobody needs an ECG, and 25 mg is tiny, minuscule dose. The full dose is 100 mg. In studies, they've gone up to 800 mg with no major side effect. And I have several patients who on their own, we can't prescribe it, but who on their own take 150 or 200 milligrams of sildenafil or 40 milligrams of tadalafil. Tadalafil, the normal dose is 20 mg, and with that high dose, then they are able to perform.
About nitrates, just one message from me. Cardiac patients are often incorrectly prescribed nitrates for long term. Suppose they have come out of a myocardial infarction, they will be with a prescription of Improper or Rismoritat. Do remember that nitrates do not reduce mortality, morbidity events. They are only meant for chronic stable angina. And if the patient does not have chronic stable angina, you may be giving the nitrate incorrectly. So as he said, you can request withdrawal by asking the cardiologist for the nitrate. So about differences between, you said there is sildenafil available, there is avanafil available, there is tadalafil. Are vardenafil and sildenafil available or not available?
So vardenafil, only one company was making it, but availability is very limited. So vardenafil is not in the picture, and its profile is almost identical to sildenafil. Sildenafil, tadalafil, very different profiles and make for the most important comparison. Sildenafil is in between. It's the politician who keeps on jumping parties. So sildenafil is more expensive but doesn't have a major advantage. Avanafil is recent. Cipla launched it last week. Zydus launched it a couple of months ago. And avanafil may have milder side effects. But the key product you'll be looking at is sildenafil, tadalafil. So what is the difference? Sildenafil onset is a little faster, and the duration of action is for a shorter period of time. The half-life is 6 hours, so onset is within 1 hour and it carries over for about 12 hours. Tadalafil, half-life is 17 and a half hours. So the peak onset is after 2 hours and the effect can be seen up to 48 hours. So tadalafil is often called the weekend pill. And the joke is, oh, tadalafil, great. Saturday it works at home and on Monday it works in the office. So many MNC couples who are having sex only on the weekend, we'll tell them, okay, Friday night or Saturday afternoon you take the tadalafil, and then that gives them the freedom for spontaneous sex throughout the weekend. Some of the MNC couples give them tadalafil 10 mg twice a week, Tuesday and Friday, and that is sufficient because of the carryover to give them the little boost that they need. An older patient, diabetic, hypertensive, I would prefer sildenafil because the carryover effect is shorter, so that in event of him having any problem and needing other treatment, the sildenafil is out of his system. The side effect profile also varies. Sildenafil is more likely to cause headache and visual disturbances because it acts on PD6. So lights may look a little bluish. So if you're giving it to a pilot, he should not be flying for 48 hours afterwards. And you need to warn your patient. I know of one patient who wound up in the emergency at midnight because everything was looking blue. Tadalafil can cause headaches but less likely, will not cause the visual effect because it doesn't affect PD6, but because it affects PD11, about 10% of patients have severe backache or leg pain. So you need to warn them about that, and if they get that, then you switch from tadalafil to sildenafil. And efficacy-wise, they're roughly similar. Patients have specific preferences. I have patients who tell me, Doc, that one didn't work, this one works great, and vice versa. So the take-home message is, start with any one, keeping in mind the frequency of intercourse and the age of the patient, and I'll talk about that again. Start with any one, review after a few weeks, and if it is not effective or if the side effects are too much, switch to the other. And sometimes the other will work when the first one didn't, or the other may have very tolerable side effects while the first one was not tolerated. If somebody is having very frequent unplanned sex, then tadalafil is better. If it's an old stable couple for whom sex is every Wednesday or Friday, then sildenafil is more predictable and perhaps a little more effective. So clinical scenario, young patient comes, Doc, I've been married last 3 months. My erections come and go, but they're not stable. I'm losing my confidence. Often it's associated with premature ejaculation, which we will talk about later. That is a young boy whom I may put on just 5 milligrams of tadalafil every day in the evening. And that gives him great erections. Comes back in 10-20 days, Doc, you're the best. Very good. Now your confidence is there. Let's reduce it to alternate days. And normally with alternate days, he'll do equally well. After 20 days, we make it twice a week, and then we wean him off the drug. So you play around with the drug once you understand the patient's need and requirement.
Those equivalents, you said 10 milligrams of tadalafil is 50 milligrams of sildenafil.
So 10 milligram tadalafil is equal to 50 mg sildenafil. 20 mg tadalafil is equal to 100 mg sildenafil. 5 mg tadalafil is equal to 25 mg sildenafil. Now 25 mg is used uncommonly, 5 mg is used commonly. The reason is that because the half-life of tadalafil is long, even 5 mg given daily has a cumulative build-up and can therefore be more effective than sildenafil 25 mg.
Family physicians, as you know, we also use 5 milligram everyday tadalafil for BPH in lieu of alpha blockers sometimes. Is that right?
That's right, but I feel the alpha blocker is more effective.
More effective, okay.
So if somebody is having sex once in a fortnight, then giving him tadalafil doesn't make sense.
No, we usually would use it when alpha blockers cause postural hypotension more
Yeah,
than anything
if
else.
they're
If they're not
causing
tolerated.
hypotension,
Like,
sure,
or retrograde
certainly.
ejaculation is a common problem with alpha
Certainly.
blockers. Yeah.
And that's an important point which Dr. Tushar mentioned, that alpha blockers, two side effects, postural hypertension and reduction in semen volume due to retrograde ejaculation. If that is bothering a sexually active male, then tadalafil is a good option.
Might be a good option. So, he...
Okay,
What
what
is
do you
the
start
starting
with?
dose? Yeah.
Usually I start with 50. So very often my prescription to a patient is tablets sildenafil 50 mg, one strip, which is usually 4 tablets. Try 50 mg tomorrow. After 3-4 days, try 50 mg again. And if on 2 occasions it has not worked, on the 3rd occasion take 2 together. So it's 100 mg, and then come and report to me. So I have his feedback on 50 and 100. The reason why I don't jump to 100 is the likelihood of minor side effects like headache, stuffiness of the nose, etc. is higher with a higher dose. And sometimes patients stop using the medication because of the side effect. If you build it up slowly, the chance of compliance will be greater. And you also want time interval, very important again. So often I say a prescription, take it half hour before sex. Peak levels are reached after 1 hour. Secondly, food delays the absorption of sildenafil. It doesn't affect tadalafil much. So when sildenafil first came to India, we would follow the literature. Have your dinner, wait 2 hours, take the tablet, wait 1 hour, then have sex. When the patient came back, how was it? Sir, what, how was it? By the time that was over, my wife was asleep. So then we realized that if we want to give sildenafil, we tell them take it half hour before dinner. So it gets absorbed. And as I said, the effect is for 6 to 8 hours. Then he has the freedom to have sex whenever he wants without having to look at the watch. 29 minutes, 1 minute more. So that way, if it's tadalafil, the absorption is less hampered by food. So they could take it any time. But again, I would recommend 2 to 3 hours before sexual activity. I'll come to alcohol. Sure. So the question, important question. Alcohol, yeah, a couple of glasses of wine, couple of pegs of whiskey, 1 bottle of beer is okay. If they have much more than that, see, these drugs very often cause mild hypertension or nausea or acidity, and too much alcohol will worsen that. But it can be consumed with a little bit of alcohol. The other question was young patient on chronic tadalafil doing very well. Most of them will tend to recover. Now again, you have a young patient who's unmarried. I would give him tadalafil for some time, he'll have great erections. When I stop the tadalafil, his erections will diminish because his anxiety has not been completely relieved. That patient, I tell him that, see, now we know with the medicine you're fine, but your final cure will happen only after marriage. And this is very important because all these young people say, Doc, once I'm cured, I will get married. And the advice to them is you will get cured after you are married, once you have regular sex. But when you get married, that is when you will have to take the medicine for 2, 3, 4 months till you gain full confidence. So if it's a young unmarried male, we give it for a period of time just to boost his confidence, then taper it off. If it's a married male and he's doing well with daily, doing well with alternate day, not doing so well with twice a week, you go back to alternate day, let him have a couple of months, regain his confidence, go into the sexual history. Is there enough foreplay? Is he relaxed? Is there pressure from his wife? Is there some other problem? And if those problems are resolved, then you'll be able to taper him off the drug. Like in Bombay, very often families don't have privacy, particularly in the lower socioeconomic classes. 1 room, 1 curtain, up on the loft, and then they have to have sex. It's circumstances where they cannot be adequately aroused, and they may need to take the medicine forever. And that is fine, it will not harm them. The risks, the long-term risks are very rare, and there are 2 risks. Rarely, and rarely means very rarely, there can be hearing loss. So if a patient on PD5 inhibitor says, Doc, I'm getting ringing or I cannot hear, stop the drug, ENT referral. And in diabetics, if they already have optic disc congestion, then very rarely there's an entity called NAION, non-arteritic ischemic optic nerve atrophy. Very, very rare. So neither of these complications is a reason to not give the medication long term. I have lots of patients on long-term medication. But just be aware, when you talk to them casually, tell them hearing is fine, vision is fine, and if that rare event happens, take them off the drug.
I have heard that there are some ophthalmic contraindications like retinitis pigmentosa, RP, where you may not give. Is that true?
Sure. So, as I said, having a well-informed chairman is such a pleasure. So, because sildenafil affects PDE6, which is in the retina, it is contraindicated in patients with retinitis pigmentosa, but not in other conditions.
Okay.
Tadalafil has no impact on PDE6 and can be given in this condition. Avanafil doesn't act on PDE6 and can be given.
Okay. Sir, I have a question, Dr. Gajre.
Yeah, very nice. So if we pass the mic around, that's nice.
If he has already taken tadalafil and sildenafil and he requires to take a nitrates, what would be the gap?
question would be if he's taken tadalafil, sildenafil and he gets angina.
Yeah.
Then you manage him without nitrates.
No, probably I'll modify the question. The patient is a chronic stable angina patient, needs regular daily ISMO retard or Imdur, and now needs sildenafil. Can you have gaps
if he's
between
on
the
regular,
doses?
needs regular nitrates, do not give him sildenafil.
Okay.
But tadalafil can be given or no?
No PD5 inhibitor.
No PD5 inhibitor.
In fact, there we use intrapenile injections, which we will
Which
come to,
correct.
because that drug acts there. But the other scenario where he's not on chronic nitrates,
Yes.
he takes the tablet and now develops chest pain, no past history of nitrate use.
Yeah.
That patient for 24 hours after sildenafil or 48 hours after tadalafil cannot be given nitrates. And in fact, my cardiologists tell me that now nitrates are kind of passe. Even if somebody gets chest pain, give them the aspirin but not the nitrates.
Correct.
And then the cardiologist has to be told, I've taken sildenafil, and of course they'll use all the other therapies.
Thank
but
you,
do
sir.
not give a nitrate.
Yeah.
Hearing loss and ringing, can it be
Into the mic so everybody can hear.
Sorry, hello. Yeah, in ringing of the ears and hearing loss, can the PDE5 inhibitors reintroduced after some time or anything else?
It's so rare that we really don't know. But if somebody had ringing of the ear, I would be scared to reintroduce the tablet because I don't want him to have hearing loss from that. But these are very rare. I've had, I think, 1 or 2 patients in 35 years.
Sir, but is the hearing loss kind of permanent or is it reversible?
Again, we don't
What's the
know.
pathophysiology?
The one patient I followed up for some time still had some loss, still he stopped seeing me.
Sir, leg pains of the tadalafil is worse than the atorvastatin. That's what the patient's feedback.
What was the question?
Leg pains because of the tadalafil is worse than the atorvastatin at times. So though it is
Statins cause muscle pains.
is tolerable.
What he's saying is statin muscle pain is often tolerable, but tadalafil muscle pain is often intolerable or
Yeah,
very
because
severe.
see, the muscle pain comes from an action on PDE11. And sildenafil doesn't have any inhibitory action on PDE11. So therefore, the muscle pain comes with tadalafil.
But can it be incapacitating? Was
Oh
what you're
yeah, that
asking.
muscle pain can be very painful. I have patients who for a couple of days require high doses of analgesics. What is surprising is, after they've had this pain and they stop, and if they restart tadalafil, somehow the pain very often doesn't come back.
Wow.
So I've had people on low dose, they got pain, they stopped it, but they started again, and then they were pain-free.
About efficacy of PDE5 inhibitors going down over years.
Sure. So common question that is asked is there tachyphylaxis? But your question is better worded because does the efficacy go down? Yes, it goes down. Does it go down because of tachyphylaxis? Tachyphylaxis is specific tolerance to the drug. That is less likely. More often the efficacy goes down simply because the original medical condition progresses. Somebody has diabetes, atherosclerosis, over time that's going to worsen and therefore the efficacy of the medicine will go away. But I do have patients who tell me, Doc, first month it was great, but then it has stopped working. And I think there a certain psychological element is also at play. The first few times it's new, it gives a great erection, but then the original psychological pressures start playing on their mind again. So efficacy can go down.
Okay. That will bring us to the PD5 inhibitor failures, initial failures or failures after some time. How do we tackle that?
So very important to acknowledge that they are failures, because too many doctors will give a PD5 inhibitor, but when it stops acting, tell the patient, okay, that's the end of the line. Not true. If you go back to the original research on Viagra, the seminal paper was in 1998, New England Journal of Medicine by Goldstein. Even then, in their disease-wise categorization of response, only 50% diabetic men responded to the highest dose of sildenafil. And even men diagnosed as psychogenic, 1 in 4 men with pure psychogenic ED did not respond to sildenafil. And there's an important reason why that, which is also an important point to bear in mind when you counsel patients while giving the prescription. Often patients will take the tablet and wait for an erection. That doesn't work, because sildenafil requires cyclic GMP and nitric oxide production before it can act. So there has to be arousal. The parasympathetic nerves have to release nitric oxide. That has to stimulate the release of cyclic GMP. The cyclic GMP then causes a cascade which causes erection. Sildenafil is acting at the cyclic GMP level. If there is no arousal, there is no cyclic GMP and no erection. So if a man is very tense, or a man is aroused, or a man doesn't have foreplay, the tablet will not act. So in fact, when we get patients who say, Doc, you gave me the tablet and it did not work, the first thing we do is, did he take it at the correct time? Did he take the correct dose? And did he have adequate stimulation? And many of them will say, no, I took the tablet and I waited and nothing happened. So then we explain to them and tell them, no, you have to take the tablet before dinner so it is absorbed, not your 25 mg but 100 mg, and after an hour and a half. Sometimes they're very anxious. So I tell them, after an hour and a half, sit by yourself, fantasize a little, self-stimulate so that the cascade is triggered, and then go to your partner and start foreplay, and then the tablet may work. So that's a very important point to bear in mind. So related to that, because sildenafil needs arousal, if a man has psychogenic ED also, 1 in 4, the tablet may fail. So there's a huge population where the drug may not work, and the first step is, as I explained, ensure that the correct dose at the correct time with the correct stimulation was used. If a man is over 50 and diabetic especially, they may be prone to significant hypogonadism. And in such men, correcting the testosterone level over a period of 2 to 3 months may improve the response to sildenafil. If the diabetes control is poor or lipids are very high, bringing those back to normal may improve the response to the tablet. So these are things that you can do at your level to ensure a better response. And of course, as I mentioned earlier, switch from one to the other tablet. Sometimes that may work, and unofficially you can tell the patient to try a higher dose. If he's taking 100 mg and not having side effects, he could try 150 mg. Don't write that, but you could tell him orally.
The maximum dose technically is 100 mg of sildenafil.
Or 20 mg
tadalafil. But occasionally a patient may respond to a higher
now,
dose.
if with all these measures he's still not responding, and there's a large number who won't, then there is much more that can be offered. It's certainly not the end of the road. One of the things we do, in fact, what we used to do even before sildenafil came, was inject vasodilator drugs directly into the penis. Now that sounds scary, but you use a 31 gauge insulin syringe. It's virtually painless and highly effective. 50% of men who do not respond to the highest dose of a PD5 inhibitor will respond to an intrapenile injection of a vasodilator. So what do we inject? If you look at Western literature, they talk about prostaglandin. Very expensive, quite painful, not available. We don't use that. Pure papaverine, easily available, very inexpensive, but not effective and very painful. So instead, what we use is a bimix. which is a mixture of papaverine with an alpha blocker. And the alpha blocker can be phentolamine or chlorpromazine. In combination, it's highly effective as PGE1, but much cheaper. Doesn't need refrigeration, so it's very easy for the patient to take home and use at home, and requires a much smaller dose, and therefore is very easy to inject and painless.
So we'll just repeat it for them. Papaverine with phentolamine, papaverine with chlorpromazine. Two combinations called BIMIX, Bimix. Is Bimix a trade name?
No,
Or just
Bimix
name?
is a description. So Bimix is not commercially available. We make it ourselves in a clinic. Papaverine, phentolamine is described in literature. Chlorpromazine is actually our innovation.
Chlorpromazine is your...
Because phentolamine was not available. Recently, a patient from Hyderabad contacted me, "Doc, my injections are over, what shall I do? I can't get it locally." And then on his own, he went on the net and he found that, I assume one of my students who is more enterprising than me, is now commercially selling the Bimix
Wow.
online. So you can order it online off the internet. So I've not ordered it. I don't know if it's fraudulent or not. But for I think 1,000 or 1,200, he sells an ampule of 4 ml. However, I would not recommend that you should be using the Bimix, because Bimix carries the risk of too much of a good thing. With sildenafil, priapism is extremely rare, not a concern. But with Bimix, because it is so potent, a patient could have a prolonged erection. So you should be aware of it, because certainly it's a very useful tool, a very potent tool. And if you have a significant practice in sexual medicine, then you should learn how to inject the Bimix and how to treat a prolonged erection. There are many workshops which are being held by sexual medicine societies. They explain this very well. Usually the diabetologists invite me to talk once in a while, and this is again the subject when I talk to them, how to inject and how to treat a prolonged erection. So Bimix, the combination, very effective when other measures fail, very safe. Even patients who require nitrates can take the Bimix, because the Bimix is acting only locally. So how do we use the Bimix? When a patient comes, "Doc, I was already given sildenafil, it has not worked, I've gone to 4 doctors, nothing has helped, can you help me?" We will first inject the Bimix in the clinic. The first time in a low dose, if it doesn't work, next time in a high dose, to reduce the risk of a prolonged erection. If he gets a good full erection with the Bimix, till then we don't talk about self-injection, because he'll run away. Self-injection is scary. We tell him we are going to do a diagnostic test. We inject him with the Bimix. He gets a good erection. Says, "Doc, this is the best erection I've had in 5 years. It lasts for half an hour or 1 hour." Then we tell him, "Very good. That means that with this medicine, your blood vessels are opening up. So we will start with a course." We don't tell him forever. We'll start with a course of injections for a couple of months. And so that you can use it properly, we will teach you how to self-inject. "I can't self-inject." "Don't worry, we will teach you twice, thrice. Here is a little brochure, you can see the technique." Day before, patient asked me, "Doc, you must be having a YouTube explaining this." I told him I'm too old for YouTubes, but my assistant was with me. I told him, "You better start your app and have a link to how to self-inject."
In fact, there are many videos, I must tell you, that have a selection of them.
Okay, so then we tell him, "Don't worry, we will teach you how to self-inject." So they come once or twice, and we guide them in the self-injection technique. And the very first time when we have injected, they realize that it is painless and it is effective. And that is a very strong motivator in getting them to learn self-injection. And while they are learning self-injection, we may increase or reduce the dose to find which dose gives them an erection lasting for about half to 1 hour, which is the optimal time. And then we actually pre-fill their dose in an insulin syringe, put it in a Ziploc bag and give it to them. And it doesn't need refrigeration, so they can hide it in the drawer. And when they want to have sex, they just take the Ziploc bag. They don't have to fill, they don't have to prepare. Just open the bag. There's a little pouch with spirit. Apply the spirit in the bathroom, inject. massage for 5 minutes, get the erection, come out and pretend they're Superman.
So it does not need arousal in that sense like PD5 needs?
It needs arousal by self-stimulation.
That's all, okay.
Because the drug still requires nitric oxide cascade, but to a much lower extent. So we tell them after you inject for 5 minutes, self-stimulate and fantasize. But then the erection will persist.
Okay.
So the duration will depend on the dose and the medical condition. Somebody has very severe vasculogenic ED, even with the full dose, he may lose the erection in 10 minutes. A young healthy male, you inject 10% of the full dose, he may get a priapism. So it's very important to start with a low dose and then build it up. From 0.1 ml to 1 ml. So 0.1 ml is just 3 marks or 4 marks of an insulin syringe.
So all of us, if we need to consider intracavernous injection, we'll obviously have to refer the patient to an andrologist. How many such andrologists in the city of Mumbai who will teach the patient?
Andrologist or urologist is
Okay.
fine. Some sexologists also do it because we have been teaching them. And it's not difficult. So anybody who's really interested in this, you have many patients, you can learn. Many years ago, 20, 30 years ago when this was just started, the largest self-injection clinic in Australia was run by diabetologists, not urologists, because in those days urologists were disinterested and there were so many diabetic men who needed it. So any physician can actually take over, just have a urologist on call in the rare event of a prolonged erection.
Can a sexologist prepare the concoction in his
Can be
clinic?
done.
Can be done, okay. There's no marketed concoction.
Yeah, as I said, now online someone is selling it,
but not otherwise.
officially no, officially it's not recognized, it's an off-label use.
Correct.
But it's adequately documented and published in literature.
There is no intraurethral injection
There is
of
intraurethral pellet available which is called Muse, and I call it a Muse because it doesn't work. It's Muse's medicated urethral system for erection. It's a prostaglandin pellet, costs $20 each, highly ineffective, causes burning in the urethra. And the only reason why it's mentioned is that several of the directors of the company that make it are very well-known international andrologists.
Oh, okay.
A wife will get the side effect. A wife may be happy. In fact, I'm surprised you didn't ask me Viagra for women.
Yeah, Viagra for women. You did specify that andrology is my area.
So Viagra for women, short answer. See, women are much smarter than men. Men's brains are between their legs, women's brains are between their ears. So for men, you give them Viagra, they get an erection, they're ready to go. Women were given Viagra. Pfizer spent more than several $1 million researching them, and they found that with Viagra, there was increased flow in the vagina, in the clitoris, but it did not translate into better sexual activity for women because the mother-in-law was more important than the Viagra. So that's why they stopped. However, I've had occasional couples where the woman has told me, Doc, I do use Viagra and it makes it easier for me to have an orgasm.
There are
Can sildenafil cause priapism? Very, very, very rare. So it's not even something we discuss with patients, but yeah, there are incidental cases.
maybe you can differentiate prolonged erection from priapism.
Yeah, so erection for 1-2 hours, common, but that's not priapism. Priapism is when it becomes painful, so that is beyond 4 hours. The most cases of priapism are when a young male who is completely normal overdoses himself. When given medically, it's extremely rare. Somebody develops a priapism. So if somebody has a prolonged erection and contacts you within 2 to 3 hours, one, ask him to masturbate and ejaculate. That can often cause the erection to go down. And 2, make him hold his ears and do 30 sit-ups.
Oh,
The ears are for fun. The sit-ups divert the blood to the legs and may cause him to go down. And I have one patient who's a doctor in interior Maharashtra who told me, Rupin, he's on self-injection. Very low dose. He says, Rupin, whenever I have a prolonged erection, I smoke a cigarette and my erection goes down. No, the cigarette, nicotine causes vasoconstriction. So in fact, there was a very interesting study done ages ago by Tom Lu, very well-known researcher. He actually took monkeys, exposed their penile vessels, put a probe on the penile vessel, measured the blood flow, and then he blew tobacco smoke into the cage and demonstrated a marked reduction in the blood flow.
Nice.
So I sometimes tell my patients that story to scare them away from smoking.
Yeah. That's why also cigarettes are usually smoked after sex.
Yeah, not before. Good one. To drain the blood. So then we are talking of how do you actually surgically treat it. If an erection has persisted, but it is within 4 hours, normally injecting an alpha adrenergic agent into the penis will cause it to detumesce. So that could be 100 micrograms of adrenaline or 500 micrograms of phenylephrine. But you should do that only if the penis is fully erect. If it's already partially detumescing, never inject the drug because it will enter circulation. If the erection has persisted beyond 4 hours, or if the patient is hypertensive and you don't want to use an alpha adrenergic agent, then you can drain the blood. 18 gauge you will use if you don't like the patient. Otherwise 22 gauge is more humane. And that you can stick into the side of the penis, not into the glands. You don't need local anesthesia. You can look at the birdie and pluck it in, and then just allow the blood to drain out passively. And usually in 15-20 minutes, draining 50 to 100 ml of blood, the penis will go down. So one patient, in fact, recently sent me an email saying, Doc, I did it twice. And what he did was, he took a 20 ml syringe and a scalpel in, plonked the needle in, and then allowed the blood to come in easily into the syringe. Actually, you should not aspirate. If you aspirate, you drain too much blood too quickly. You need to allow it to come slowly, drip by drip.
This was a medical person.
This was actually, no, he was a lay person, but an extra smart lay person.
Okay, about, sorry.
So if they binge drink, I would tell them on that day, don't go for sex. You're going to fail and you'll lose your confidence.
Whether alcohol,
The question was
binge
the
drinking.
MNC weekends, they're binge drinking. They go to the bar and then one after the other. And then they want to have sex. Likely to fail. And I would tell them that not a good day. If you want, you can try, but if you fail, don't take it to heart. It doesn't mean you have a problem.
About, she's saying about sports persons who
They feel weak
after
afterwards.
sex.
Not only players, a lot of people tell me, Doc, after sex I feel very drained. And for some men, orgasm is like that. And we tell them, yeah, that is why you do it in the evening and then sleep out the night. And if a player feels tired, you can refer him to any of the numerous movies on sports where players are told, don't have sex. And all footballers instead go and have sex and still play football the next day. So it's logical. If the man feels tired, he shouldn't do it. There's no treatment for that. No, some people feel very drained. In fact, there is a very interesting entity, I'll just sensitize you to it, called POIS, P-O-I-S, that is post-orgasm, what is I? Post-orgasm I syndrome, I'll remember, where some men actually after they ejaculate for almost a week have severe depression, withdrawal, extreme symptoms. They can't even go out. And initially we used to think this was psychogenic, but now we recognize that this is a real entity, maybe some kind of hyperallergic response to semen. And if you go on the net and type POIS, post-orgasmic syndrome, it's quite mind-blowing, and you need to be aware of it, because once in your career you might find one patient who says this, and it's a real entity. It's not hypothetical and it is not imaginary. So maybe your football player has a very mild version, or your sports player has a very mild version of that.
So what happens if a person has got a very heavy meal and then he has sexual activity?
Person is very
Very heavy food.
very heavy meal.
Yes.
So a very heavy meal is going to divert the blood where it is more needed. So it's more likely that he will not get an erection. So when we are prescribing the tablet, we tell patients don't have a very heavy meal. It should be a light filling meal, but not too heavy.
Thank you.
Usually when I'm conducting evening lectures, I warn all the audience that the kind of meal you're going to have after my talk is contraindicated for sildenafil. That syndrome we spoke about earlier.
Patients with pulmonary hypertension who are kept on sildenafil 25 milligram. Now if they want to take or do, does this have any effect on their sexual life or anything? Because I think they used to give, I don't know, now they are giving for pulmonary hypertension.
Sildenafil is one of the drugs used to treat pulmonary
Yeah,
hypertension.
so 25 milligram they give BD or TDS. So does that have any effect on?
No impact.
Does that improve their sex life in
No, it
terms of-
doesn't affect the sex life.
Okay. Eyes, illness.
Sorry.
Sorry?
Some leukemia patients have priapism as a problem.
Priapism, what are causes of priapism? Priapism can be idiopathic. We don't find a cause. It could be hematogenic, sickle cell disease, leukemia, polycythemia. It can be drug-induced, some of the antipsychotics or narcotic drugs. Very rarely it can be sildenafil-induced, or it could be iatrogenic following an intrapenal injection.
So can high-dose statins improve the prognosis? No?
Can high dose?
Statins in
Can high-dose statins improve erectile
inorganic
dysfunction?
diseases, yeah.
Can high dose of statin improve? Yeah, there are some papers showing that some statins can improve erectile function.
We'll just finish erectile dysfunction before we take more questions. Role of arginine and yohimbine, which are drugs sometimes.
So yohimbine was very popular before sildenafil came, and we used to prescribe it quite a lot. In Mumbai it was manufactured by Atul Drug House at Worli, but it didn't really help. And arginine now is being promoted very widely. Personally, I don't think it helps.
Just a second. Ravi, वो mic बंद कर दो. Off ही है. Okay. कुछ disturbance आ रहा है?
Yeah, there is a sound somewhere. Maybe it's an indication for coffee break.
It's ready? Coffee is ready? Okay, we'll just take the last. Yohimbine, non-allopathic drug, would you say?
No, yohimbine
Is allopathic.
is an allopathic. It's also used, I think, in non-allopathic combinations when there are many, many things in it. But yohimbine, once sildenafil came, yohimbine became redundant because it's not really effective.
Arginine,
Arginine is promoted very widely and people give it every day. I don't think it helps.
it doesn't
It
work.
doesn't work only. That's what I said. It doesn't help.
Okay, and then some people make money out of platelet-rich plasma injections.
So the question gives the answer. The question was, some people make money out of giving PRP.
So don't you like them? Do you like them? Do you like such people or you don't?
Do I like people who make money out of platelet-rich plasma? No, I don't like people who make money out of platelet-rich plasma, or as they call it, the PiE shot.
PiE shot,
Sounds
is it?
even more dramatic.
Okay, we'll break for coffee, 10-minute break. There is coffee and tea outside. Please come back in 10.